A very big hello to all my dear students. So, how are you all? Welcome to the T2O series from your favorite channel, You and I with Dr. Ruchika. So, we are going to continue with some important topics around our INICT exam as I discussed in the last episode. So, few more phobias that you all have. I'm here to solve it. Let's see. Yeah. What is the diagnosis in this patient? Whenever you have this type of question, first thing is to always observe the eye in the primary gaze. What is the position of the eye in the primary gaze? Can you see this? There is a left hypertropia, isn't it? So this patient has got, to start with, we will think like this, left hypertropia, right? So when there is a left hypertropia, do you all understand what it means? This is suppose my left eye, left side, and this is my right. Either the left depressors are involved or right elevators are. Isn't it? Correct? Okay. So what are the left depressors? You should be very, very clear about your action of muscles. 6 muscles, actions that you should know. Right? So for your depressors, you know the two muscles which depress your eyes, inferior rectus, superior oblique. So either it is the left inferior rectus or left superior oblique, or it is the elevators of the right side which are involved. That is, I'm so sorry, did I say left inferior rectus? No? So left inferior rectus and left superior oblique, yeah, and or the right sided elevators, that is right superior rectus and right inferior oblique. Right? So once you're clear about this, we come to the next, what you see is the next figure. And do you all know this concept should be very, very clear to you all that when you talk about the action of muscles, what are the muscles? You should be very clear about the yoke muscles. You all know yoke muscles are contralateral synergies. So yoke muscles, when I'm looking to the right, it is my right lateral, left medial, sorry, and this is left lateral, right. Now this is quite easy. Right lateral, left medial, left lateral, right. What happens when you're looking at this gaze? This is dextro elevation. How to think about this? First thing you have to think is, what are the muscles which elevate your eye? The superior rectus, inferior oblique. Now think, the next thing that you have to think is, which eye is outward? So can you see the right eye is outward and the left eye is inward? Keep in mind, make a box and you can note it down. Then in an outward or deviated eye, the action of elevation and depression is of recti. And vice versa, for inward deviated, it is the oblique. So when I'm looking like this, it is my right superior rectus and left inferior oblique which are working. So if it is dextro depression, again my right eye is outward. What are the muscles which depress? Inferior rectus, superior oblique. So it is right inferior rectus, left superior oblique. Sorry, levo elevation. This time it is my left eye which is outward. So left eye correct eye is working. So it will be left superior rectus and right inferior. This should be very, very clear. Then we understand this question better. So next thing that you have to see, once you know which eye is hypertropic, in which gaze is hypertropia increasing. So as you can see very clearly, on the opposite gaze here, the hypertropia increases. Here the eye looks almost normal. So when this is increasing here, what does this mean? The left eye is in an adducted position, isn't it? So either when it is increasing on the left side, that means either it is the oblique of the left side or recti of the right side, isn't it? So hypertropia is increasing, goes up in opposite gaze, goes in favor of left superior oblique or right superior rectus, any of these. Isn't it? So these were the 4 muscles here which we have in doubt. Either the left depressors are gone or right elevators are affected. Left depressor means left inferior rectus and left. Right elevators means right superior rectus and right inferior oblique. Okay? Correct? Now we are saying it is increasing in opposite gaze. So it rounds about to either it is the left superior oblique or it is the right superior. But we have to also see the head tip. So on tilting the head on whatever side, suppose in this case, can you see here? on the opposite side, the eye looks almost normal. That's why the compensatory head posture of an SO palsy is opposite head tilt. But when you tilt the head on the same side in which there was hypertropia, on the same side head tilt, the hypertropia increases. Okay, head tilt, hypertropia increases. So you have to understand this. If you're tilting to the right and the hypertropia increases, either it is going to be right intortus or left extortus, and vice versa. So when you're on this case also, if it is increasing in the left side in this patient, left hypertropia increasing. So this was the left hypertropia, and on the same side head tilt, it is increasing. So it has to be either the left side intortus or right side. Correct? So this complicates a little further. I would make it more simple for you all. Just remember this, because they won't ask you more than this. They are only focused on SO palsy, that in SO palsy, hypertropia is going to increase on same side head tilt and opposite gaze. Okay, then it is S. So here the answer becomes left SO palsy. Okay, right, all of you? So what have you just learned with me is your part 3-step test. Okay, so now I don't think it's very difficult. 3 steps are nothing but 3 questions. So in this case, I'm very quickly revising again with you so that you are clear. 3 questions. Which eye is hypertropic? In this case, it was the left. That means left depressors, right elevators. Next question. In which gaze is the hypertropia increasing? On the right gaze. Opposite gaze. Now we round about to 2 muscles here. Either it is left superior oblique or it is right superior rectus. Isn't it? Then what is the next thing? Is head tilt. That is the third question. On which side head tilt the hypertropia increases? So part 3-step test are 3 questions. Which gaze, and what was the third question? Which head tilt? So if you are tilting the head, as I explained you, towards the left side, in this case there's a left hypertrophy. So left intortus will be in what? Right? Superiors are intortus. Which is the intortor in question here? Of the left side, it is only superior oblique. So on tilting the head on the left side, if hypertropia is increasing, it has to be left superior oblique palsy, because this is the intortor on the left side. Or it could be extortus of the right, and I don't want to complicate into that. Just remember this way. Okay, so this is what is SO palsy, the features that you have to remember, and this is part 3-step. They will ask you this much. Now, if you look at this slide, again you will see there's a left hypertropia which is increasing on same side head tilt, and on opposite side this is all normalized. Now, what is this test called? This Bilchowski sign. So when you are looking at the head tilt and seeing whether hypertropia is increasing on which side head tilt, this is what is Bilchowski sign in SO palsy, where same side head tilt leads to increase in hypertrophy. Now, here I'll just explain you why it is happening. So, in this case, in this question of yours, the patient has a left hypertropia. When you are tilting the head on the same side, what did I explain you? Left intort, because you have to look at the straight, the left side should intort. So, what are the intorters? Here's our intorters. So, once I tilt the head like this, to look straight, the intorters have to work. Superiors are intorters. That means this side left superior oblique and left superior rectus. What happens? Superior oblique is already paralyzed. Whole responsibility goes on superior rectus. What is the primary action of superior rectus? Elevation. This is the reason there is increase in hypertropia on same side head tilt. And this is what is called Bilchowski sign. There is overworking of superior rectus as an intortor, and primary action will play first. So there is increase of hypertrophy. Why? Because there is already SO palsy. Okay? I hope this time now it's clear and you will be able to solve these questions. Come to the next one. I think this was a very recent question and a lot of debate around this question. I haven't put the question here. It was around patient having proptosis and fever. What is the diagnosis? The image was given to you. Let us all understand this according to the Chandler's grouping. What is preseptal cellulitis and what is orbital? You all know there is the orbital septum, like a wall of the orbit. Anything in front is preseptal. Suppose there's an insect bite, a lot of swelling. Not dangerous because it's not involving the orbit. This is preseptal cell. It won't cause any problem. And this is the reason, if you look here, there's a lot of swelling, but there is no proptosis. The level of the eyeball is same. This is your preseptal cellulitis. Here, but in your question, the patient had proptosis. So this is excluded. Now there can be two possibilities. Either it goes to orbital cellulitis or there is a subperiosteal abscess. That will depend upon the picture that was given to you. Subperiosteal abscess would look something like this, right? So this is your so if suppose there is a proptosis here, so either this one is your subperiosteal abscess, and if the picture was something like this where the orbit is involved, there's thickening of the fascia lining, then this is your orbital cellulitis. So you have to be a little bit alert here. What is the image given? Okay. Any orbital inflammation, there has to be little proptosis, and you also know that orbital cellulitis is an emergency because of risk of causing cavernous sinus thrombus. So this is your grade grouping 5 of Chandler's grouping, cavernous sinus. Okay, now it's clear. Come to the next one. Again, a repeated question, an important topic to revise. Everybody should know horizontal gaze center, vertical gaze center. Horizontal gaze center is PPRF. You can see here, that is paramedian pontine reticular formation, which is the vertical gaze center, that is nucleus of Cajal or Cajal, whatever you want to call, and interstitial nucleus of Cajal, or second RI, rostral interstitial MLF. These are the verticals. They have just want you to know the name. So I have just given very quickly to revise with you the name. Now coming to the basics of a horizontal gaze. I just told you, no, when you're looking on the horizontal side, this is right lateral, left medial, left lateral, right medial. That means this is what the PPRF has to do. Maintain the lateral rectus on one side and medial rectus on the other. कैसे करता है? Let's first draw to understand. Suppose this is the PPRF of the right side. Learn in my style, if this is on the right side, it orders the lateral rectus of same side. Okay, so it will order the lateral rectus of right side. This is ipsilateral innervation. But for the left eye adduction, it is going to go contralateral. It is going to order the MLF. And it is the medial longitudinal fasciculus that is further going to order the medial rectus of the same side. This is also ipsilateral. What is contralateral? One side PPRF, other side. समझ आ गया? So if I'm looking to the right, right PPRF orders the right lateral, orders the left medial through MLF. Through MLF. MLF अपने आप काम नहीं करेगा. It is the PPRF which will order. Right? And if I'm looking to the left, it is my left PPRF which will order the left lateral rectus, and right MLF, and right MLF will order the right MR. I think it's clear, absolutely. Now talking about this is further managed by opposite side. That means left-sided frontal eye field. This is another thing we will keep in mind. Correct? Now, once you are very clear, let's have a look here. This is your PPRF. Everybody knows supranuclear control, then nuclear, then the nerve, then the muscle. So if this is the PPRF orders the nucleus of sixth nerve. Through the sixth nerve, it finally innervates the lateral. Now, it will also innervate the opposite side MLF of the left side, going to third nerve nucleus, and then contracts the medial rectus. And this PPRF of one side is managed by frontal eye field of the other side. Easy? If you're drawn with me, it's very easy. Okay, so once you've done this, why it is called internuclear, can you understand? Any lesion, first let me explain you this. Any lesion of MLF is what is called internuclear ophthalmoplegia. This is important. Why it is called internuclear? Because it is between 3 and 6 nerve nucleus. So this internuclear ophthalmoplegia would have what are the features? We all know if there is an INO, what you see, side where MLF is gone, no adduction here, but other side abduction is possible. What happens? No adduction here. This abducting eye shows ataxic nystagmus. So there can be ataxic nystagmus on abducting eye. Okay? Is it clear? So this is what you have to know. What is horizontal gaze center? How does it work? What is the lesion of MLF leading? If there's a lesion in the PPRF, right side PPRF chala gaya, so right no abduction, left no adduction. The whole right-sided gaze is gone. Left-sided PPRF is gone, so left-sided gaze is gone. But common sense, if left-sided FEF is gone, frontal eye field, it will be right horizontal gaze palsy. Right-sided frontal eye field is gone, left horizontal gaze palsy, because innervation to PPRF here is contralateral. Right? So this is what we are seeing here. This is primary position, the eyes are normal. On right side, no problem. On left gaze, we see no adduction here. No adduction means it's a right MLF lesion. Isn't it? Right-sided, no adduction, right MLF lesion. And left-sided, this is which nystagmus? Ataxic nystagmus. We are looking at the case of INO. This was also your INSCT exam question. Coming to the next thing is this one. If you look here, this time the baseline is not primary. What are we looking at this? Can you see there is no adduction, no abduction on one side, and there is no adduction on this side, on the left side. Right side, no adduction, no abduction. Left side, no adduction. So why this is happening? This is right side, no adduction, no abduction. This is what you're seeing here. See, understand here. No, if right PPRF is gone, and suppose right-sided MLF is also gone, क्या होगा? Right PPRF is gone means on the right side no abduction, and on the left side no adduction, because right PPRF is managing these two. But right-sided MLF is also gone, so no adduction. This is what is called. This is what is happening. See here. That means on the right side, no PPRF is also not working and MLF is also not working. Same side, both are gone. This is 1.5 syndrome. Okay? So 1.5 syndrome means one means both adduction, abduction, half means only adduction. So this becomes 1.5 syndrome. Right? Okay. So these were some important topics which I needed you all to revise with me. Read it more thoroughly. Okay, so thank you so much and all the best. Stay blessed. Keep smiling.